All right, good afternoon, everybody. I couldn't think of a better time for a transition to lunch for the nutrition lecture. This was not planned. So this is a topic that I don't think gets a lot of attention. It's mentioned, but as you'll see as we get into it, the literature's kind of muddy and it's not great. But it's important to know what's out there when our patients ask us what to do with these situations. So once again, I have nothing to disclose. So when thinking about our patients with wounds, and we've talked about vascular disease, we've talked about infection, we've talked about all sorts of stuff. Now we're going to talk about nutrition. So along with this, there's a lot that affects us. These patients have a lot of things going on. We talked about vascular disease, tobacco abuse, age, diseases, it goes on and on. But when we're thinking about this, we're thinking about wounds. What do they need? They have a higher metabolic need because we're asking the patient to repair tissue. It's not just having intact tissue. We're asking the body to do more. And the wound healing should require optimal nutrition. It makes sense, right? Adequate nutrition can enhance this healing, but what does that mean? So we're going to start off real basic, and then we're going to work through some of the literature in general on nutrition and wound healing as a greater body of literature, and then we'll go into diabetic foot literature. So real basic, glucose, main fuel, collagen formation, fat. It's a concentrated source of energy, helps transport fat-soluble vitamins, and in general, you need roughly 30 to 35 kilocalories per kg per day. Underweight, you may need more. Overweight, you need to estimate your resting energy expenditure, activity, and wound factors. Protein, important. Synthesis of enzymes for wound healing, proliferation of cells, collagen formation. If you have a depletion of protein, you have decreased skin, fascial wound breaking strength, increased risk of infection, and you should have somewhere between 1.25 to 1.5 grams of protein per day for chronic wounds. In the severely catabolic state, a little bit more. A little bit on some of the other vitamins here before we get into the literature. Vitamin A, it's a fat-soluble vitamin. It's thought to stimulate the immune system, increase macrophage and monocyte in the wound during inflammation, and may enhance wound healing. The daily recommended intake is between about 2,300 and 3,300 international units, and wound healing anywhere is reported between 10 and 50,000 international units. Vitamin C, we all know and love here, and sometimes patients may like vitamin C or orange juice just a little too much. It's a cofactor in hydroxylation of proline and lysine. It can help provide tensile strength and newly built collagen, and can act on fibroblast proliferation, capillary formation, and neutrophil activity. Daily recommended intake about 70 to 90 milligrams a day. In wound healing, somewhere between 1 and 2,000 milligrams per day has been suggested. If you start to notice in some of these, you're going to see these wide ranges of recommended amounts, wide ranges of stuff that's looked in studies, because it's just not very well described. Vitamin D, it's another fat-soluble vitamin that can regulate calcium, synthesized in the skin, or from dietary supplements. Deficiency, just like with any other nutrient, may impede wound healing. Zinc got popular for a while, can impact immune function, protein and collagen synthesis, cellular proliferation. Once again, another important nutrient here. Some micronutrients, magnesium and copper. They also have other described factors such as being necessary for collagen formation, tissue growth, and with copper, expression of VEGF. So in the malnourished patient, by definition, there's some kind of nutritional imbalance. And this doesn't necessarily mean to be malnourished, you have to be small and cachectic. With the malnourished patient, you have increased medical costs, length of stay in your hospitalization, increased morbidity and mortality, and decreased quality of life. So, in short, does nutritional status make a difference? In general, sure, it does. We see that. We'll talk about some of the greater body of literature first. And as you'll see, it spans a lot of different pathologies, and a lot of the literature does not separate that. It combines them all, as you'll see, which makes it hard to make assumptions, especially about our patient population. But as you'll see later on, the literature is lacking about the value and importance of nutritional intervention for patients with foot ulcers. Starting off overall, broadly, looking at nutritional supplements and wound healing, and you're going to see this a lot, nursing home, elderly patients. This one, a 50-patient geriatric study, multiple wound types, as you can see here. And the intervention that they did is they used different nutritional supplements without a control. It was either 4 or 8 kilojoule per mil supplements, 80 mils for three times a day for 4 weeks. Both groups had significant improvement with wound depth in 4 weeks, and there was no difference between the groups in 4 weeks with the wound depth, and there was no difference in complete wound healing. But like I said before, there's no real true control with this. Both groups had some level of intervention. Lee's paper in Advanced Skin Wound Care, this is looking at pressure ulcers using a collagen protein hydrolysate supplement. And this is an RCT in the space looking solely at pressure ulcers. They had 71 stage 2, 3, or 4 pressure ulcers in nursing home residents. This is roughly 2-to-1 multi-center RCT where they use 3 times a day supplements of 15 grams of hydrolyzed protein or placebo for an 8-week period. Their primary outcome was a push score, and as you can see here on the side in table 2, there were differences in the groups over time, and the rate of healing was significantly higher for the treatment group across the 2, 6, and 8-week period. What they did not do was evaluate the difference in wound severity, complete healing, or other wound care treatments. Uhura's article in Wound Repair and Regeneration looking at the nutritional intervention of pressure ulcers in their nutritional states, they had 62 fed patients with stage 3 and 4 pressure ulcers, once again, multiple sites. This is an open randomized 1-to-1 trial for 12 weeks, where they had a caloric difference between the groups of 300 kilocalories with a protein difference of 12. What they did do is they excluded severe diabetes, and they excluded wounds with greater than 20% necrotic area pre-debridement. It's like, hey, we're kind of interested in those patients. They used, quote, standardized wound care, standardized offloading and turning. But then they excluded 8 of the 30 patients from the intervention group. 4 were withdrawn due to lack of efficacy, and 4 were withdrawn for some kind of prohibited treatment. It seems a little odd to me to withdraw due to lack of efficacy. They only reported their raw data. But when we actually analyze the data, the p-value is 0.17, so not significant. When you add back in the 4 patients who were non-responders, the p-value is 0.31. So going to the international working group, I love that they have been mentioned multiple times here, and it is, like Dr. Labber said, a great group with free resources where you can go and get all this. They flat out say, do not use pharmacologic agents to supplement vitamins and trace elements to improve wound healing outcomes over standard of care. There you go. That's the end of the presentation. No, just kidding. What they did do is they evaluated vitamins E and C, D, daily probiotics, and omega-3 fatty acids. So what is there in our space in patients with foot ulcers? We're going to look at some of those studies that the working group looked at. As you can see, there's a smattering of interventions that were used. Looking at proteins and amino acids, Enteroth in 2004 looked at Wagner 1 and 2 ulcers. They had 26 and 27 patients in each arm for a 4-week course, 400 kilocal protein supplement versus a placebo given once daily. Outcomes, there was no difference in wound healing at 6 months between treatment and control, and no difference in wound healing at 6 months between patients with and without protein energy malnutrition. Armstrong in 2014, this is a UT grade 1A ulcers with 130 and 141 patients in the arms for 16 weeks. This is 79 kilocal arginine, glutamine, and beta-H-beta MB drink, or Juven, versus 88 kilocal low glycemic response supplement given once daily. They found there's no difference in healing at 16 weeks, no difference in time to healing. What they did do, they did a post hoc subgroup analysis showing that there was a difference in healing at 16 weeks if albumin was low at baseline. Jones in 2014 looked at chronic diabetic foot wounds present for at least 30 days, 6 to 3, and for 2 weeks. They used an arginine, glutamine, beta H, beta MB drink versus placebo, which was not specified. They didn't really give any clinical measures. They did note an increase in tissue hydroxyproline concentration in the treatment group, though. You're going to start noticing a theme in these outcomes. Vitamin D, Mozaffari, Khosravi in 2016, Wagner 1 and 2. If you think about what Dr. Lavery talked about earlier, a lot of these studies look at some of the more, I guess you could say, healthier patients with foot ulcers. They had 23 and 24 patients in the arms, looking at 150,000 versus 300,000 units with a 4-week follow-up. There was no control with this. There's no difference in the ulcer area between the groups, but a higher dose of vitamin D yielded higher serum level concentrations of vitamin D. But they also noticed lower fasting blood glucose and lower serum CRP. Razagi in 2017 looked at Wagner 3s. Okay, this is getting closer to what a lot of us see every day. 30 and 30 for 12 weeks. And they looked at a 50,000 unit vitamin D every 2 weeks versus a placebo. And they saw a decreased ulcer length, width, and depth, A1C, but they did not report healing or time to healing. Campbell in 2020, also another vitamin D study, Wagner 2 and 3. They did 60,000 vitamin D for 12 weeks versus nothing. Same thing, they saw decreased wound surface area, decreased A1C, increase in serum vitamin D, but did not measure healing or time to healing. Magnesium and vitamin E, Afzali in 2019, Wagner 3. To spare you all the details here, we're seeing very similar things. You're seeing decrease in measurements, improvement in fasting glucose and A1C, but did not measure healing or time to heal. Are you starting to see why the working group does not recommend this based off the current body of literature? Magnesium, same author in 2018, Wagner 3 diabetic foot ulcers, doing 250 milligrams a day of magnesium versus placebo for 12 weeks. They saw, once again, you give them magnesium, the serum level goes up. They saw a decrease in ulcer length, width, depth, but once again, did not measure healing or time to healing. Starting to sound like a broken record. Zinc, looking at this, Wagner 3 again. They gave a zinc supplement versus placebo, and would you look at that? It's the same thing. Omega-3 fatty acids, also in Wagner 3 diabetic foot ulcerations, 1,000 milligram per day flaxseed oil supplement versus placebo. And again, decrease in length, width, and depth. So there are some improvements in measurements that you see here, but yet no one looked at healing or time to healing. And then probiotics. I thought this was interesting. This isn't really something that I thought about before really digging into this, but they looked at probiotic supplementation in patients with Wagner 3 diabetic foot ulcerations. And they did see some of the similar findings as the other nutritional supplementation studies. Vitamins E and C, Yaramati in 2021, back to Wagner 1 and 2 ulcers, an 8-week study. And if you also notice, these are small. This is 13 and 12 patients. They gave PRP fibrin glue, used PRP fibrin glue dressings, vitamin E, 200 units, and vitamin C, 250 units versus placebo. And there was no difference in healing, and there was no analysis actually done in the paper. So if you look at this, you really have to tease this apart. Is there some kind of impact? Yeah, there is. We saw that there were some changes in sizes. But going back to the International Working Group's recommendation that they do not recommend using this for wound healing at this time based on the current literature. We see some changes in the surrogate markers, such as wound size, but none of them looked at actual healing of the wounds. Thank you very much.